Good morning, and welcome to the House Insurance Committee this morning for Tuesday, February 22nd. Mr. Clerk, will you please take the roll?
Representatives Carr, Sapicki, Freeman, Hawk, Hicks, Hodges, Johnson, Lafferty, Mitchell, Powers, Rudd, Smith, Terry, Thompson, White, Vice Chair Lady Rudder,
Here.
Chairman Kumar. Madam Chair, you have a quorum.
Thank you, Mr. Clerk. Thank you, Mr. Clerk. Do we have any personal orders? I would just like to wish Chairman Kumar and his wife Linda a speedy recovery this morning, and that we're thinking about them. So let's see, members. Today we have two bills on the calendar. Item number one is House Bill 2655. Chairman Hawk, you're recognized.
Thank you, Madam Chair and members. We do have an amendment. What House Bill 2655 is going to do, it basically removes the sunset provision from our telehealth that has worked well during the pandemic time and will continue that allowable system. We've got an amendment coded 014001 that will, thank you. And what the amendment does, it provides the proverbial belt and suspenders to ensure that if there's a declared emergency, a tornado happens somewhere, that it's not declared across the state, and just to kind of give clarity to the whole system. But essentially, what the amendment does, it continues the efforts of telehealth and removes the sunset. So that's the amendment and the bill itself, Madam Chair and members.
Thank you, Chairman Hawk. Members, do we have any questions on the amendment? Seeing no further questions, are we ready to vote on adopting Amendment 014001? There's no objections. All in favor of adopting Amendment 014001, please signify by saying aye. Aye. Anyone opposed? The ayes have it. The amendment goes on the bill. Now we're back on the bill as amended. Members, are there any further questions for the sponsor? Seeing no further questions, we're ready to vote. Are we ready to vote? No questions. Is there any objection? All those in favor of sending House Bill 2655 to Calendar and Rules signify by saying aye. Aye. Those opposed, no. The ayes have it. House Bill 2655 moves on to Calendar and Rules.
Thank you, Madam Chair and members.
This brings us to item number, the second item on our calendar, and that is House Bill 1843. Chairman Terry, you're recognized.
Thank you, Chairman and Committee. What this bill does, it simply adds healthcare services to current telemedicine practices that allow audio only for behavioral health services. Currently, CMS recognizes audio only health services, and this bill would line Tennessee up with what is currently allowed by CMS. And with that, I'll stand ready to take any questions.
Yes, Representative Rudd.
Chairman Terry, does this definition change also, does it in any way affect the compensation rate for audio?
Chairman Terry.
I'm not sure I understand the question that you're asking. There are, for CMS, there are codes that are out there, and there are rates tied to those codes. Is that what you're asking?
Representative Rudd.
Well, it's saying that it's kind of a simply worded bill, but I think does it, and I'm asking questions, I don't know. I'm getting conflicting information when I ask questions of people over the past few days. By changing this audio, like right now, telehealth, we passed telehealth last year, where telehealth is paid the same rate as an in-office visit. Would this bring this audio back up to be paid the same rate as telehealth by changing the code? Is it forcing insurance companies or anyone to pay doctors at a same rate as telehealth for just a phone call?
Chairman Terry.
There are rates that are tied, my understanding, to these codes. and they would be different rates than different levels of service. So the codes here is 99441, 99442, and 99443. So there would be rates tied to that. If you do a different level of service, there would be rates tied to that service, if that's what you're asking.
Representative Rudd?
I guess, and it's already, I guess, is it already legal right now? And these are questions I don't know. No one's answered, so I'm asking. Are these, audio conversation now, is it legal now? Of course, this is a very narrow defined part of the practice, but is it legal now for doctors to talk and prescribe to their patients or renew prescriptions? Or are they limited in this category right now?
Chairman Terry?
You can call your office. What this is that it would be, like, for example, from a diabetic, you would have to be an established patient, and you will not have been in their office within the last 7 days. And then whatever comes up, based off your conversation, if you meet the criteria between, I think 99441 is at least a 5-minute conversation with them where you do an evaluation, and then you do your medical management at that point in time, and you meet those criteria, document that criteria. So from a diabetic standpoint, you're an established patient with your physician, and say you step on something and you get a cut in your foot, and you call your physician, you have a conversation with them, you have directed it. You can't have immediate access to the video portion, so it would be just the audio only. They do an evaluation over the phone. They're able to tell you maybe that during this time, you may want to give more insulin. You may want to tighten up what your glucose control is. If you don't go back to their office within the next immediate short period of time, it says leading to an E&M service or procedure within the next 24 hours or soonest available appointment. So if that doesn't happen, and you're not, don't have to have a procedure or anything that for the diabetic foot, then you could bill them based on these E&M codes.
I guess that's the main thing. They're already able to talk to their patients and do that. I don't really understand quite what the bill is doing, except from the way I understand code, it would fully compensate. It would fully compensate audio to a physician, force the insurance companies to pay. And I have not talked to insurance companies, so that's why I'm asking questions. It would force to reimburse doctors at the same rate for talking to a patient over the phone as they would coming into their office for an exam or through telemedicine. And I was concerned about that. That's the only question I really had, if the code changed where compensation's been changed.
Representative Terry?
Yeah, I would have to look on here, but I think that the code for like a E&M service for audio only, I think on here was like $45, whereas an office visit, if you came in, would be, maybe $100. So that would be a different rate. I think that's based on this code. We may have somebody that could, if we need to go out of session, we may have somebody that can answer that question for us.
Yes, we do. I have someone here from the Tennessee Medical Association who would like to testify on this bill. And so without objection, we're going to go out of session. Please come forward and have a seat and give us your name for the record.
Julie Griffin, Tennessee Medical Association. Thank you all for having me today, Madam Chairman and members of the committee. I'm going to answer your question first. The rate would be tied to what the E&M code is for that. You are correct. It would tie it to that E&M code, which is what the payers would have to pay based on that negotiated rate for the in-person visit. What I want to make sure it's clear is that there cannot be any deviation from the standard of care of whether or not that patient was in the office or whether it was an audio-only call. It is only a last resort. This is not going to be something that happens very often because the patient it's not whether the physician has access to technology, it's whether the patient has access to broadband, whether they have access to a smart device that would allow them to do a video conferencing. It's we had testimony in subcommittee from one of our cancer specialists here in Nashville who sees a lot of patients 2 and 3 hours from here because there's not a lot of cancer specialists. He says less than 5% of his telemedicine visits would even qualify for one of these visits. So we're talking very rarely would this be happening where you would have to be able to provide the same standard of care as what that visit would require. It also requires significant documentation to prove that that visit was medically necessary. And if that documentation is not there, if say the payers thought that there was an individual physician who was misusing the statute, there is utilization review. Therefore, if they do not find that the documentation that that provider is putting in the record meets the definition of medical necessity, they can either recoup the money or not pay that claim. So they have a lot more power to look at what that doctor is doing. Right now, during the pandemic, most of the payers were paying for this at the same rate because people couldn't get there. What we found were particularly cancer patients. I know the Disability Coalition is very interested in this piece of legislation. The Heart Association, the Cancer Society, we are all supporting this bill because those are people who are having to travel great distances from very rural communities that may not have the access or the means to be able to do the video component. And so, yes, it is at parity because you're encouraging the continuity of care of that patient. They're an established patient. They have bricks and mortar that they can come into. This is just saving them that trip because they can't get the video component. If that makes it, did I answer your question?
Representative Rudd.
Yeah, to a degree. I guess the main thing is what we were talking about is granting the way it's written. It's a very simple bill and it
Mhm.
changes code, but it doesn't say what the code does. And that's what I was wanting. Doctors can already treat their patients. This is more about compensation than it is
Mhm.
granting permission, and that wasn't really in the bill. We're talking about that, so that's all I was asking
What we
questions about.
when we discussed this bill with Chairman Terry, um, we were trying to keep it in line with what you all passed last year for behavioral health, so that it was exactly as you all had already approved the language for behavioral health. We're really talking about three, maybe a few more codes, but three primary codes that would be allowed for audio only other than what you all have already approved. And those are, I'm not going to give you the numbers because I know y'all don't care about the numbers, but those three codes are the evaluation and management codes that don't necessarily require you to have your hands on that patient, but preferably our doctors would like to always have the hands on the patient. That's the way they prefer to do business. If they can't do that in this day and age of technology, telehealth has turned into a viable option. They would rather see that patient if they can. But there are just some instances. I think Dr. Terry gave you one as a diabetic patient who may have to travel 2 hours in order to see him, or not him, but the physician, and they could evaluate what's happening with that diabetic patient, make adjustments over the phone because that diabetic patient's able to keep their blood sugar levels at, you keep that at yourself. You're managing your own blood sugar levels at home. Save that patient the 2-hour drive only because they didn't have the video component. And it wouldn't change the standard of care of what they would have gotten had they been in the office, had they had the video. And just making sure that physician is compensated at a rate that what they would be compensated had they been in the office.
I think our next question is going to come from Representative Hodges.
Thank you, Madam Chairman. And so you said earlier this would only be used as a last resort. And my only question would be where does it state, where is it defined by last resort? I mean, what would keep a bad actor from going to, their local pub and making 20 calls and collecting a copay?
There are things that are tied to this statute that we're amending that would prohibit that from happening. First of all, the physician has to have access to the complete medical record in order for this visit to take place. So they don't have access to the complete medical record in a pub, I can guarantee you. So it's not going to happen in pub. I've heard on the golf course, doctors picking up the phone and just calling patients. It has to be a patient-initiated visit in order for it to qualify. So the patient has to be reaching out to the physician for some level of care, for the level of care.
You're recognized.
So, that's not stated in here, but then the other question would be, who's going to determine that that person wasn't in the bar, or, like you said, on the golf course, making those phone calls?
Well, first of all, this is just adding language into the current statute. So the statute that it's being added to has all those safeguards in it. So it's just tying that back to the same statute that requires the patient initiated and to have the access to the medical records. So that's what's required now for a video visit. And that's what this would be tied to. And the behavioral health is the same way. In addition, there is utilization review. And if the documentation, and trust me, doctors have to document or they will get recouped. If they can't prove the medical necessity of that encounter, then they are going to be recouped by the insurance company for that visit, and they won't get any payment. So there are already safeguards in the statute to try to defer. Could there be a bad actor? There could be a bad. People find ways around statutes all the time. That's why you all are here. But I think we've got the safeguards in place to discourage that. And so I just think the safeguards are there to make sure that you don't have somebody on the golf course, because they're not going to be able to provide, they're not going to have access to the complete medical record. And just to keep in mind, there is a lot of telemedicine out there or telehealth, I should say, telehealth out there that is audio only, but has no continuity of care. The Teledocs of the world, which I know many of the payers promote to their participants, that's the kind of audio only, except the difference is they don't have to have access to a complete medical record. They don't have to be subject to the same utilization review unless it's in their contract. And I don't know if it's in their contract or not, but they're not subject to the same statutes as necessarily what we're talking about here.
I guess with the teledocs, and I could be wrong, that's a negotiation that the insurance company has made
Correct.
with the teledocs, where we're mandating that the insurance companies pay a set price.
Because we're also mandating that these doctors still have to maintain the bricks and mortar of an office. They can't do this because part of in order to qualify for telehealth, you have to have seen that patient in person within the last 16 months. So we're making sure that these are folks that are having the bricks and mortar. They're maintaining the medical record so that you have full access to all the information about that patient. Because one of the things that I know our folks really get concerned with the teledocs of the world is that you may have someone who calls a teledoc because they've had a major sinus infection, 3 months in a row. But 3 months in a row, if that doctor had seen that, might be able to determine that maybe there was something else going on with that patient. That brings the continuity of care together to make sure that patient's getting not just care for the symptoms that they're receiving, that they have, but truly looking at what is going on with that patient as a whole that may be causing those sinus infections.
Yeah, in concept, I want to tell you, I think this is a great idea. I guess I just don't see the safeguards, and I worry that we've seen what a few bad actors could do with the opiate epidemic, and so I just worry that the safeguards aren't there, and that you could just have a guy making a bunch of phone calls to get some copays when he's on vacation, get some extra money. I mean,
Well, again, they'd have to document that the patient didn't have access to, because it says when it's the technology's not available. So they'd have to document in the record that the technology was not available
for the doctor or for
for
the
the
patient?
patient, for the patient. And I am fully, if that needed to be clarified that it was the patient didn't have access, we just wrote, or Chairman Terry wrote the bill to make it clean as you all, because last year you all approved this very language for the behavioral health side.
Hmm.
So we were just dropping in the other services because we wanted to keep it consistent with what you all had already approved in the last General Assembly.
I do think clarifying that the patient doesn't have access would make a world of difference for me anyway, but thank you.
We have Representative Smith has a question.
Thank you, Madam Chairman. And one of the things I just want to read from the current code. And the current code says in 56-7-103, Section A, C, or 6C, notwithstanding any other subdivisions, this HIPAA compliance, audio-only conversation for the provision of behavioral health services when the means described in subdivision above are unavailable, meaning the visual component. So essentially what this is saying already in code is that audio only is not the first, the patient, as said in the code, the patient doesn't have access to a virtual mechanism. If they're in Hancock County, or if they're in even parts of Hamilton County, sometimes you don't have cellular coverage. And so I think what's confusing is, and there's a little bit of hyperbole here, we all know insurance companies deny claims. And so there's nothing that mandates coverage. There can be a denial of claim. Okay? And so what I understand this bill to do is, in the case that the virtual, the synchronous exchange of information by video is not available, then this would be a fallback. And that if the care that can be delivered over the phone, clearly you can't bill for a blood pressure check, because you can't take someone's blood pressure unless they already have remote patient monitoring. You can't take a blood sugar sampling unless they are doing it themselves. So the guidelines are the existing codes. Is that correct? Okay. Thank you, Madam Chairman.
Thank you. Are there any more questions? Seeing none, we'll go back into session. Thank you. Members, we do have a few more questions for our sponsor. We'll begin with Chairman Sapiki.
Thank you, Madam Chairman. There was a statement made about quality. How, Chairman Terry, how does the doctor maintain the quality in an audio-only phone call versus a video audio call versus in-person seeing the patient? How do you maintain the same quality in all three of those situations?
Chairman Terry.
Thank you. Great question. I will tell you right now, for an in-person visit, there are different codes that line up with different actions that the provider would take. Some of the lesser codes that are out there do not require a examination on the patient. They require your evaluation, which would be getting your history of the present illness, knowing their background, and then you making so that's your evaluation, and then you making a medical decision. And so you can make an evaluation and a medical decision without actually doing the video component. And I'll give you an example. So in medicine, we're taught oftentimes when you go see a patient, these are established patients, you often will do what's called a SOAP note. That's subjective, and that's where you're listening to what the patient says. The O is the objective, and that's where whatever objective signs you do from a physical exam. A is the assessment, and P is the plan. You don't always have to do the O. You don't have to do the objective portion of that. Sometimes the term that we use is called SBAR, and it's what's the situation that the patient's currently in, what's their background that you have, what's the assessment, and what's the recommendation. And so that is what you can do over the phone with a patient. You can do an SBAR and do the evaluation and do the management that way.
Chairman Sapiki.
So I appreciate that answer. So from that explanation, I feel you are saying that there is no difference in care for the patient versus in-person, audio, video, or audio only. It's the exact same care that the patient is going to receive in all three situations. Am I interpreting that correctly?
Chairman Terry.
I'm not sure that's if you are doing an evaluation of that patient and you determine that you don't have to do that objective portion of that, then you would be held to the same standard in all three of those.
And one more, ma'am. One more, Madam Chairman.
You're recognized.
So if I understand this right, it's the patient that has to that has to not be able to gain video access. How do you determine that the patient doesn't have video access?
Chairman Terry.
Thank you. That would be, I think the code says immediately available, and that would probably, I'd have legal answer how they would know. I mean, you couldn't tell if the patient was lying.
We'll go out of session and ask legal.
Zach Brown, Legal Services. Chairman Terry, you said that, you were saying that that the code refers to the services being immediately unavailable. Searching right now, I'm unable to find the word immediately in the code section 56.7.1003. However, subdivision A6C says again that the let me just read it here. Compliant audio-only conversation for the provision of behavioral health services when the means described in subdivision A6A are unavailable. So just unavailable.
Question for legal.
Yes, Chairman Sapiki.
So based off of that question, the legal is there's nothing in the law currently that identifies how someone would determine that video is unavailable.
Chairman Spicky, based on section 56.7.1003, that would be correct.
Thank you, Madam Chairman. Thank you.
Any more questions for legal? If not, we'll go back into session. Any more questions? Yes, I think we do, Representative Freeman.
Thank you, Chairman. And so I remember this debate from last year when we were talking about behavioral health services. And we talk quite a bit about how to comply with HIPAA requirements. And having seen it firsthand, I can speak to the great success that specific piece of the code has been within behavioral health specifically. And I think expanding to all services is a good idea. And I keep hearing people talk about the cost, and could someone be, at home or something. And I think we're maybe missing it. We're not necessarily talking cost of what it costs to provide the service. We're talking opportunity costs of a provider. And as a user of healthcare, I want to make sure that I get the best service possible. And so I want to make sure that when I call my PCP or my specialist, that I'm getting them. And in order for us to ensure that they are the ones picking up the phone, I think we need to reimburse them appropriately. We don't reimburse based on cost, on what a doctor makes, on what they don't make. We don't get a discount if we get a cheaper doctor, or a doctor that doesn't negotiate for the right pay. And so I think that maybe we're missing some of the argument, maybe not, but I support this bill. I think it's a great idea. There are several people that don't need the visual aspect of the telehealth. People that are sight disabled and on that need the ability to pick up the phone and call. And so anyway, I just support this bill and wanted to say those few words. Thank you.
I think next on our list is Representative Powers.
Thank you, Madam Chair. And to the sponsor, I just wanted to check, you mentioned the codes a while ago that are currently using this in CMS. They're doing it in Medicare, Medicaid, both. And those are not in there permanently, are they? Wasn't this particular provision put in there temporarily through the pandemic? And if so, are they going to adopt them permanently, or is there any expiration date on that?
Chairman Terry.
Thank you. Great question. This was brought up in the subcommittee, and it's my understanding that they are working to make this a permanent code. And in the event that it does not go permanent, then these codes would go away. And so what we're basically doing would be putting this in statute for these codes. And then if it goes away, then they would not be able to bill off these codes.
Oh, okay. Okay. Thank you. Thank you, Madam Chair.
Are there any more questions for our sponsor? Seeing no further questions, are we ready to vote? All those in favor of sending House Bill 1843 to Calendar and Rules, please signify by saying aye. Aye. Those opposed, no. The ayes have it. This 1843 moves on to Calendar and Rules.
Thank you, Chairman and Committee.
Seeing no further bit. Yes. Yes. Chairman Hawk.
Thank you very much. And forgive me, he had to leave the room, but in case you get sick or injured today, the doctor of the day is Dr. Howard Harrell. He's from my district, so don't give him a lot of work, but if something happens, he's here for you. So Dr. Harrell, if you're outside, you've been recognized. Thank you very much, Madam Chair.
Thank you, Chairman Hawk. Seeing no further business, without objection, we stand adjourned.